Dear students, in continuation of the rapid review cardiology for NEET and other exams, today we take up an important topic where high degree of suspicion is required for the diagnosis and may lead to deaths, almost in some series is 30% or so, because they present as sudden cardiac death. Pulmonary embolism. The embolus from different parts of the body, mainly lower limbs, DVTs, post-operatives, land into the pulmonary artery, causing acute asphyxia, I should say, and hypoxia, of course. So the true incidence difficult to estimate, but possibly in our country it must be this much, quite much. Important. 33% present with a sudden death, as I told you, and majority of the people die because of the failure of the diagnosis rather than the inadequate therapy. Therapy is there, but degree of suspicion has to be kept very high. Keep your eyes and ears open. Keep yourself well acquainted with the post-operative wards and the places like intensive cares and neurological wards. The true incidence, of course, difficult to estimate. So what happens in hemodynamic collapse? Massive embolism. Number one, that triggers these 2-3 things. What are these? Vascular obstruction from the thrombus itself, vasoconstriction by the inflammatory mediators which are released just then, and hypoxia. Elevated pulmonary vascular resistance leads to right ventricular outflow and right ventricular outflow hypotension, I should say, and decrease in preload leading to decreased cardiac output, hypotension, maybe fatal hypotension. So this is the sequence of events in pulmonary embolism. I repeat for you that there is a vascular obstruction from the thrombus, vasoconstriction secondary to the inflammatory mediators. This hypoxia results in elevated pulmonary vascular resistance, resulting in decreased ventricular outflow, which decreases the preload of the left ventricle, so the low output and hypotension. This is the sequence in pulmonary embolism and takes place very early. Another thing is elevated RV valve tension. Mind you, right ventricle is the ventricle of importance here as far as the acute core pulmonary is concerned. Because of the valve tension, there is decrease in the right coronary circulation and lead to secondary ischemia, pressing the subendocardial branches of right coronary artery, leading to troponin release also. So what is the presentation? 3. Acute core pulmonary, I was talking about just now. Pulmonary infarction with pleuritic pain, hemoptysis, RAP. Dyspnea because of such a hypoxemia and a massive occlusion of both the lungs. So what is the varicose triad? A triad which leads to embolism. I mean the thrombus formation is stasis. Important thing, stasis, immobilization, hypercoagulability, basically, which may be there hereditary by factor V laden and all this, and the injury to the vessel wall. All these 3 lead to thrombus formation. So what are the situations where hypercoagulability is there? Factor V laden, I told you. Prothrombin gene mutations. This These things may cause hypercoagulability syndromes and lead to thrombus formations, many other places, including the pulmonary embolizations. So protein C, protein S, antithrombin, and hyperhomocysteinemias, elevated factor H, causing the thrombus formations. But if you look even meticulously for these familial and genetic abnormalities, it is very unrewarding. You don't find much, and this is to the disgust of the treating physician as well as to the patients. What are they acquired? We talked about immobilization just now. So orthopedic procedures which commonly lead to the pulmonary embolism is immobilization after the surgery, pregnancy. Oral contraceptives also lead to the hypercoagular state. We have seen many girls presenting with us with pulmonary embolism. For the treatment, these people give for the treatment of PCODs. So these are the reasons for, acquired reasons I should say, for propensity for thrombus formation and pulmonary embolism. Malignancy, anywhere. Lupus anticoagulant therapy, anticardiolipin antibodies, ACS, important. Inflammatory bowel disease. Heparin-induced thrombocytopenia is something which is undesirable, but this happens and should always be kept in mind. Central venous catheters and pacemakers, embolization from there may lead to pulmonary embolism. Myeloproliferative disorders and nephrotic syndrome. These are important reasons for acquired causes of pulmonary embolism. So sequelae of DVT and PE, what happens? Sequelae has taken place. A massive DVT, massive embolism, and the thrombosis has taken place. What can happen? Chronic thromboembolic pulmonary hypertension. Such a complication of repeated pulmonary embolism or a massive embolism in the beginning that it will lead to such a crippled life like CTPH, and a patient cannot walk even up to their bathroom. Post-thrombotic syndrome of the legs can happen, and such a thing which is again so debilitating and lifestyle modifying things. Phlegmasia caerulea dolens, emergency. Such a swelling of limb swelling of caused by malignancy and thrombotic complete occlusion, limb threatening. Very important, phlegmasia caerulea. We have seen some cases and led to death only. Pre-test probability of the embolism. Where you should look for, whether you should suspect for troponin elevation. If it is there, correlate with the ECG, and echo higher mortality is there, and RV pressure load is shown. So these are the things which should be kept in mind. BNP raise shows RV dysfunction. Arterial blood gas, there may be some exceptions, but hypoxia PaO2 is less. Always attach the patient to oximetry then and there, and you will see the saturation, which is important for the diagnosis. But mind you, even a massive thrombosis, because it was seen in the pipette study that even in a massive pulmonary embolism, the saturation surprisingly may be normal, near normal I should say. So chest x-ray for other things of dyspnea like pneumonias or pneumothorax, these things. These very fancy findings on chest X-ray are now rarely seen, like a Westermarck's, Hampton's, or a Palasine. Very deep, important, not very important to see. ECG, rule out other diagnosis. Myocardial infarction, so common as this, and most of the time you will find in the ECG a sinus tachycardia, atrial fibrillation, or a right bundle branch block. RV strain pattern is much more common than other things as far as the ECG is concerned, or it may present only with a sinus tachycardia. Echo findings, very crucial as far as the emergency is concerned. Patient is stable, no RV dysfunction, don't worry much. Hemodynamic collapse, you will definitely see RV dysfunction. Direct visualization of the thrombus may be there in echo, but rare to find. RV hypokinesia with sparing of apex, this particular thing is really very suggestive of a pulmonary embolism of the acute pulmonary, causing acute pulmonary rather than the other things like COPD and pneumonias. So important to see as far as the echocardiography is concerned. RV dilatation and hypokinesia will be there. Of course, secondary tricuspid regurgitation you will find. You will find a paradoxical septal motion affecting the left ventricular function. Pulmonary hypertension, of course, you will find, and there was such venous engorgement that is hardly collapse of the IVC during the inspiration. So these are the findings which we look into echocardiography. Ventilation perfusion scans nowadays are not very common to perform, but may suggest to rule out the diseases of pulmonary arteries. D-dimer is another one test which has got a negative predictive value. If there was not high degree of suspicion with negative D-dimer, you can virtually rule out the pulmonary embolism as a cause of this breathing difficulty. It is a rule out test, as you know, and also because it is also raised in MIs, pneumonias, cancers, pregnancy, and postoperative states. So hardly of use. So this here comes the most important test, diagnostic of pulmonary embolism. CT, pulmonary angiography, should be performed and very accurate in diagnosis. See all the important things as far as the pulmonary embolism is concerned. So in these you will see the thrombus themselves, and even sixth order branches can be visualized in the modern day CT machines. RV enlargement will also be visible. Emphysema, fibrosis, the other things causing cor pulmonale will be visible there, and proximal and distal DVTs are important to see. Sometimes CT of these vessels is also performed. We can come down during the CT performance and look into these, because the thrombuses of DVTs are very nicely visible. So very important. In the same way, pneumonias, lung cancers will also be seen in the CT and will aid in our diagnosis as well as therapy. MRA we don't usually look for. So pulmonary angiography, the real-time pulmonary angiography, we only resort if we plan for a catheter-directed therapy. We will talk about it after some 2-3 minutes. So fragmentation of and pluralization of the thrombus can be performed during the pulmonary angiography and the therapy. And the low dose altiplase is another thing which I should bring to everybody's notice, as we know that there are many contraindications to the thrombolytic therapy. So this low dose thrombolytic therapy of around 24 to 30 milligram of thrombolytic drug is safe and very effective in submassive therapies. Pulmonary infarction usually indicates a small p because the thrombus after all has lodged into the very periphery of the pulmonary artery. So these things are to be kept in the mind. Non-thrombotic PE should be kept in mind. We have seen cases, everybody has seen cases after the fractures. So fat embolism, tumor embolism, bone marrow and air embolism, cement embolism, which is used for the total hip and knee replacements, intravenous drugs. Many funny things have been found lodged into the pulmonary artery. Amniotic fluid embolism is such a thing which is such a dreaded complication during the parturition, should be kept in the mind. If you are called to see a lady in a postpartum ward with a cold and clemicine, think of embolism, amniotic fluid embolism, fatal disease I should say. So anticoagulation therapy, although many things have changed after the direct oral anticoagulants have arrived on the horizon, but we have to treat the patient on anticoagulation. Parenteral therapy used to work as a bridge to warfarin, vitamin K antagonist. Parenteral therapy as a bridge to newer oral anticoagulants or DOACs, NOACs. Not much required, but has to be given 1 or 2 dosages. In the same way, heparin-induced thrombocytopenia, bivalirudin and ergotroban are to be used. Heparin-induced thrombocytopenia is such a dreaded thing, which comes to the mind very late and leads to catastrophes. UFS, that is unfractionated heparin, is one causing the heparin-induced thrombocytopenia. Most commonly used drugs are low molecular weight heparins, which are important and should be started immediately in submassives also. Anticoagulations, fondaparonox, drug of choice in many situations, but contraindicated in the cases of bacterial endocarditis and renal impairments. Mind you, bacterial endocarditis never use a thrombolytic therapy or anticoagulants, which will lead to catastrophic brain hemorrhages. Systemic thrombolysis. I think in a massive pulmonary embolism with hemodynamic collapse, the only thing which works is a systemic thrombolysis, and we have been doing it very often. So massive PE streptokinase 1500, 1.5 million, as you know, over around 1 or 2 hours. LT-Blaze also over 2 hours. Both these medications, thrombolytics, you know, LT-Blaze is a 3rd generation fibrin specific thrombolytic, which should be given in 2 hours time. If it is submassive, then we have to use, say, heparin. And there was a study, MEPET study, which showed that the LT-Blaze didn't require, although the escalation of the therapy later on during the resuscitation, but is not that very helpful. Pytho was the another trial which was between the tenecteplase and the placebo. There has to be given in, say, 32 milligram as a single dose. Overall mortality was also less in both the groups, control as well as this, but it led to intracranial hemorrhages and major bleeding, which offset all the benefits of thrombolytic therapy. Catheter directed thrombolysis in submassive, I told you, only 20 to 30 milligram of the dosages may be required. In the catheter directed therapy only, the ultrasound assisted thrombolysis was done by the ECOS catheter in the Seattle 3 trial, and was found to be effective in some cases. A pigtail catheter disintegrating the thrombus was also used in a few centers, and angiovac system of some suction embolectomy were also used. But mind you, these are very special centers, not very often and not everywhere available. So we have got limitations regarding this. Contraindications to systemic thrombolysis, I again remind you, not to be forgotten. Intracranial hemorrhage, non-intracranial lesions which predispose to bleeding like aneurysms, malignancies, malformations, ischemic stroke within 3 to 6 months, don't give thrombolytics. Major trauma or surgery, don't give. Active bleeding, not to be given. Non-compressible bleeding, don't give thrombolytic. So these are the absolute, some relative contraindications, including the patients on anticoagulants and uncontrolled hypertensions, and look into, take the situation control, then only give the thrombolytic therapy. So anticoagulants, what are they? Newer vitamin K antagonists, including the warfarin, 2 to 3 INR, you know it very well, 5 mg starting dose. But drug to drug and drug to food interactions, very common, very unpredictable, particularly very difficult in our country. In peripheries, there are no facilities for INR. Newer anticoagulants like DTIs and 10A inhibitors are very much used, and you can see the dosages 15 mg BD and 20 mg daily after 3 weeks. Apixaban can be used if there is a renal failure. Edoxaban can also be used, and the duration of the therapy 3 to 6 months. Maybe duration of the therapy may be lifelong if there was a hemodynamic collapse in the beginning. So venous thromboembolism prophylaxis, where important. Extended duration should be seen in the say around 35 days in cases where major orthopedic replacement procedures were done. In cancer, may happen even after 30 days. Gynae cancer therapy, 35 days. Major ortho surgeries, I think 35 days, including these medications which we have already discussed. If there is a complete say contraindication, then intermittent pneumatic compression may be undertaken, and we do it day in and day out routinely in all the cases. A word about inferior vena cava filters. Previously it came with a big fancy, but has now been given up because of many factors. But indicated in cases where there is a contraindication to the anticoagulants. You can't give, put a filter. Recurrent thromboembolism, put a filter. If paradoxically nidus formation, problem for us. Collateral veins may develop, go into the pulmonary arteries. Endothelialization may take place, difficult to removal, although they are removable instruments and can be removed after say 3 to 6 months. But the thrombus forms on the device itself, and it becomes very difficult to manage this. The filter may fail in very small thrombi. Important things to be kept in mind.